Wow, you were talking to somebody else. That was amazing. Thank you very much for those kind words, and thank you very much for inviting me to Madison to share some of my ideas and what we are doing in Canada, and also in collaboration with other people. So I do sometimes have a voice of the FM radio midnight show where I start going really low and put people to sleep. If I do, please start throwing things at me and I'll work out. Already you can't hear me, right? So my talk is a little complicated in the sense that I wanted to share a few different things. As you heard from Carol, I'm involved in quite a few different things, and I wanted to share all those different things with you and see, even though you live in Wisconsin, many of the things we are doing, you will have access to it and you should take advantage of it. And so my first part of my talk is some of the research that my own research group is doing. Then I will talk about that research, what that means and what type of data that we need, not only in Canada but around the world to conduct research like this. And you heard previously talk about diabetes. And again, some of the complex things that that group wants to do in relation to risk factors and lifestyle, social and mental health. You need some big data. And then finally, I'm going to talk about how do we apply the research we do, how do we take it to people like yourself who might need that information when you go and talk to your doctor about your health. So, and there are a few slides in there that are pretty busy, and that is just to make sure because we just had a nice lunch. So I wanted to make sure that you stay awake, so that will work you out. So the first part of the conversation is that what's happening around the world? What are the two major drivers in many ways that are changing the way that the world is evolving? And some of the historians have talked about it at length. And one of the major things that happened in the 20th century and continues to happen, can anybody guess what that would be? That has changed the world, the way we see the world? Internet. What about population the growth of the world population? Like, it is going to change the climate, it's going to change the nature of the way the countries work. So historians, 20th century was for the growth of the world population, and we continue to grow. By 2040, we are going to have around 8 billion people around the planet, and that's a lot of people for this earth. But within that, there is another revolution that has happened and has had a lot of positive impact on what we do, that is going to impact the 21st century, and that is the aging of the humanity and the way people have aged around the globe, and they are aging. And in many ways, it's one of the biggest achievements of the modern medicine in public health, that people are living longer and social innovation. There are lots of good things. Aging is not all negative. It brings so many good things, but there are also challenges that we have to address. And with aging, one of the things we don't talk much is the issue of gender and aging. And if you look at the developing world, the populations are aging in those parts of the world quite rapidly. And women outlive men. And the numbers, absolute numbers of women around the world who are aging, who are not that healthy and live in poverty is astounding. So we have to think about research and application of those research when we think about aging. We also have to think about gender and aging. And also try to understand why men and women age differently and what are those processes. I think it is sometimes very easy to become very narrow and focus on your own populations like we do in Canada, or you might be working here in the USA, is that the aging is a global phenomenon. What happens in other parts of the world actually does impact us. And so when we are thinking about aging, we also have to think about aging from a global perspective. The top line here is what the developed world looks like and will continue to look like. This is countries like Canada, US, UK, Germany, France, and so on and so forth. But the population is going up to 25 to 26% of the population will be over the age of 65 by the time we hit 2050. But here's the developing world. They used to be mostly younger population, but their demographic shift is happening quite rapidly. And that their change is way faster than the change that is happening in the developed world. And I'll show you some slides, which whenever I present it, it always amazes me how these countries have managed the aging of the population. This is a slide that shows a number of years that the people, let me start again on this slide. So this is the slide where we have the more developed countries, and these are the less developed countries. The data basically shows here, if we look at France, from 1865 to 1980, it took 115 years for France to go from 7% of the population over the age of 65 to 14%. That's 115 years. Here, look at China, 26 years. They have gone from 7% of the population to 14% of the population over the age of 65. And this speed of increase in proportion of the population which is over the age of 65 is going to break these countries in many ways because they don't have the infrastructure. There are some World Bank projections are that if China is to deal with the aging population, they will have to cut their defense budget in half, and they're not likely to do that. So the social implications, health implications are enormous. And part of it has happened in China because the social engineering that has happened around family structure, one-child policy, and so on and so forth. So when we're thinking about aging, we've got to think globally because what happens there will affect us. So because economically we are so linked. If the economy of China is affected by the mass numbers of older people, and that shift, that is going to have ripple effects in other parts of the world as well. Oops. Anyways, this was supposed to be a slide of Canada and showing pyramid. That because if you look at 20, 30 years ago, they basically, oh, we'll skip this one. They basically look like a pyramid, that the most of the people, or younger people, are at the bottom end of the pyramid, and as the population age increased, and it started to look like a pyramid. But in Canada, as the population has aged, we are aging, it is becoming an upside down pyramid. And the two fastest growing age groups are the baby boomers between the ages of 55 and 64 and 80 plus. And they're very different groups. So when we think about aging and we study aging, it is not a one single population. It's a mixture of very different population. Issues and concerns and opportunities are very different, and we've got to pay attention to that as well. Sorry about that. So that's the overall global picture of the demographic shift that we are seeing and what implication that has. Now let us bring back to us, individuals in this room. How does that work? This is a hypothetical, but a typical scenario that the healthcare system or policymakers will face. Here's a Mr. X who is 78 years old, shows up for a visit at his doctor's office and complains about severe arthritis pain. Mr. X also has high blood pressure. Mr. X is also overweight and has some foot problems. And this is not uncommon. Over the age of 70, on average, people will have at least 2 chronic conditions, and many will have more than that. And the management of the chronic condition becomes very critical because a lot of us want to live in our homes, function independently, drive our cars, go do some grocery shopping, and we want to do something that promotes that functional independence that we all look for. My father, who just recently passed away, actually only 4 weeks ago, he reached the age of 97. My father's side, they all, majority of the time, reach 100, a little over 100, so I'm in trouble if I don't take care of myself. And one of the hardest things through the later part of my father's life was to manage the different conditions he had. And he was very sensitive to medications. He could not take medications. If he had to take more than 2 medications, it will actually make his functional abilities more limited. He couldn't walk. Generally, he was a very active person. So in that situation, being a knowledgeable myself, my brother, who's a physician, we sort of paid much more attention what medication he should get. Does he need to have medication for every possible health issue he has, or we have to pick and choose how that works? And that is the issue here. How do we manage this person? And policymakers, on the other hand, are dealing with a challenge when they see a group of people who have this, and that is clinical care is changing. We used to have family doctors' practices which were mostly young families. Now they are seeing more and more older people. And they used to be able to see 20, 25 patients a day. Now they can't see more than 5 and 6 patients a day. So the question is, governments or insurers or other policymakers, how do they design the reimbursement policies? How do they pay physicians to take care of the older population? They need to have a data for that. Policymakers have to make decisions at the population level to keep people in their own homes, because one of the biggest challenges we have is that lots of older people show up in the acute care sector. And if you have to treat and manage an older person with multiple conditions in a hospital in the Canadian dollars, it is around $1,500 per day. And I don't think there's a country on the planet who will continue to be able to afford that. So we have to be smart about how we think about managing the aging population. And the fact is, none of them should be in the hospitals. There should be a better, proper, well-designed community care that can take care of most of the things. But for that, policymakers need data. And we really have limited data. And you heard Carol say, we finally convinced the Canadian government to invest in creating data that will help inform some of those policy decisions. And this is what basically happens. I have lots of hypothetical scenarios here, and soon I will get to some real data. This is what the aging process is. At the younger ages, we have a lot of developmental gains. Children grow, they are developing their gains, and their losses are less. As we get older, we still develop, but our losses are bigger than our gains. And you see that there's an acute event, hip fracture can happen, you can get a pneumonia, you have a disease, and that can result in disability that might require people to be in a home or need specialized care. But the fact is that as we age, we suffer a lot of chronic conditions. And a lot of these chronic conditions can be managed. You heard something about diabetes earlier on. You don't really need to put everybody with a diabetes on a pill. You can do lots of things that don't require medication. And so the biggest challenge, the emerging challenge is chronic conditions, multiple chronic conditions, how we manage. And the other thing that I think, and Karen and I were talking this morning and yesterday as well, that the health research or medical research has gotten it wrong to some extent when it comes to the aging population, because we have focused on diseases, a single disease, but we have not focused on people who have those diseases. And when we talk about aging population, we talk about multiple chronic conditions, we have to think about how can we make older person as they age live in a healthy fashion with multiple chronic conditions, and people can. And I'm going to show you some data, what kind of impact this multiple chronic conditions has on people's functional or even their mortality, and what probably needs to be done in order to deal with some of these issues. So, as you can see, I'm building my theme of my talk towards the multimorbidity and multiple chronic condition. Older adults are at higher risk of getting multiple chronic conditions, and multiple chronic conditions, data shows to some extent is linked to increased disability, independence, and premature mortality. But we don't know yet which combinations of chronic conditions together actually puts people at risk for disability and premature mortality. And I think that's the challenge we have over the coming years to understand what clusters of chronic condition are more detrimental to one's health versus other. And I'll show you some data in a few minutes. So let me do some definitional issues. This is a researcher in me, so I have to define things. The definition of multimorbidity or multiple chronic condition is coexistence of two or more chronic conditions where one is not necessarily more central than the other. Sometimes you hear the word comorbidity. That means somebody got a cancer. Because of the cancer, they developed something else. That's not what this is. These are different diseases happening together, and they are not dependent on each other. And as I said, the multimorbidity has a major impact on quality of life, but the challenge from a research, from a clinical practice, from a policy point of view is that we really don't have a clear definition of what a multimorbidity is. A lot of research up till now has counted This says somebody who has 1 condition, 2 condition, 3 conditions, let's see what impact that has on their health. From a research point of view, that's great. But from a clinical, if you go and talk to a doctor and you say, you know, doctor, I have 2 conditions, what are you going to do for me? Doctor is going to say, okay, I need to know what type of those 2 conditions you have before I can manage. So we have to generate data that allows us to understand what combinations of diseases actually impact our health and well-being. So this is one of the projects we did, and this is based on some of the Canadian data, where we wanted to look at what is the impact of multiple chronic conditions on function and the functional limitations. Specifically, we wanted to look at diseases alone or in combination, how they impact the functional limitation in individuals. There's a bit of a statistical jargon I'm giving here. I wanted to see if you guys are awake, and I see you are awake. There's something like we wanted to see, there's 2 ways we can do research. One is to say, okay, some of the data that we produce, how it impacts individuals. So the clinical practitioners, on average, can you treat and manage it? But then there is another type of data that you want and the results you want. If you intervene at the population level, how can you change the nature of that condition in the whole population? And you need different types of measures to be able to quantify. And this is something we call population attributable risk. And so we wanted to look at what is the population attributable risk of individual and combinations of conditions. So basically what PAR does, and it's not a short version of my name, PAR indicates the proportion of cases that would not occur in a population if the risk factor were eliminated. It's a prime example I can use to explain smoking is a really bad risk factor for heart disease and cancer. So the question is, if you remove smoking from the population, you can pretty much reduce the risk of cardiovascular disease to nothing. You can reduce it substantially. So that's what the population attributable risk tells you, that if you remove that particular factor that has negative impact on health, how much better health we will get. And that's what we were trying to calculate. So we have this is an older study where we looked at 10,000 people. This is a Canadian study on health and aging. This was a study designed to look at the prevalence and incidence and risk factor of dementia, but we've used to look at some of the other aspects of health as well. So it was started in 1991 and finished in 2001. And we looked at activities of daily living, instrumental activities of daily living, and some of the complex tasks that people have to do in their day-to-day living. And these are the chronic conditions that we looked at: cognitive impairment, heart problem, diabetes, respiratory, hearing, vision problem, arthritis, and foot problems. And you can see there are some very key conditions that are not here because this data set didn't have it. That is the limitation of it. You heard previous speaker talk about mental health issues. And mental health issues become very important when we are talking about multimorbidity, because they are actually a bigger issue in younger population, even 45-year-olds. And we have to be able to look at that. And that is missing from this data set. So it gives us a picture, but it is not a complete picture. And these are the other things that we wanted to look at. I will skip this because from a technical point of view, this is basically how one of the things we did. We wanted to look at big impact diseases. So we focused on the diseases that have reasonable burden in the population, like the 10% of the population has that disease. And then we use that as an indicator to select our population. And this is what some of the data looked like. There were 3,500 or so males and 5,000 or so females. The average age in this population was mid-70s. And you can see how many people had more than 2 chronic conditions, and more so in females. And this is what the disability profile of this population looks like. The 10% had some sort of ADL, instrumental or functional disabilities, 28%, and some of them had very serious complex disabilities that limited their ability to even do basic tasks. And you can see women tend to do worse on some of those things. Now, this is the slide I was talking about. This was a test to see if you're awake. I don't want you to pay any attention to this slide. This is just, sorry. Oh, activities of daily living. And IADL is instrumental activities of daily living. And I'll show you more data on that later. So basically, just what the point of this slide is, this is what we have age groups here. And here we have male and female. And you can see the combination of 2 conditions and 3 conditions in males, and combination of 2 conditions and 3 conditions in females. This is foot problem with arthritis, and foot problems are very common with people with diabetes. And so this is not a trivial issue for older population. And here we have foot problems, arthritis, and respiratory problems, lung function issues. Here you can see ischemic heart disease. Here we have cognition, vision, and so on and so forth. So you can see that the different combinations of diseases actually give you different numbers. This is a population attributed low risk. Basically says, if you were able to remove the problems of foot and arthritis from the population among males who are 65 to 74 years old, you will improve the functional abilities of these people by 46%. So it's not a small number, and a lot of it can be achieved. So this is what this slide sort of summarizes in many ways. What we see is there's a big difference. Like, as I mentioned earlier on, that we can't think of older population as a one homogeneous population. It's quite rare. Younger, older people tend to behave differently than older. Males have different profiles than females. So when we are talking about interventions, we've got to tailor those interventions to those issues. There was a variation in magnitude and ranking of all of these risk profiles that we identified by age, sex, and also the definition of disability. I didn't show you the data on instrumental activities of daily living or the complex tasks, but you see a very different profile in relation to age, sex, and the definition of disability. Arthritis and foot problems in combination are really big drivers of the population attributable risk. And a part of this is important because there are conditions here that we really don't know what to do. The cognitive impairment dementia, people get it. There's not a whole lot of things available yet to manage or treat those conditions. But something like arthritis and foot problems, there's lots we can do. Some of it is pharmaceutical management, some of it is getting people to be a bit more active, and you can manage the pain and disability that comes with arthritis and foot problems. And foot problems, managing diabetes, doing some more lifestyle modifications. So these are the things that you can actually target at the population level, and you can change the bell curve of the population in relation to issues related to these particular conditions. And also the other big driver is the cardiovascular conditions. And so when we are thinking about modifying things, we can think about modifying diabetes and heart disease. You already heard, diabetes is a modifiable disease. By very simple things, they are not complicated things. You don't even have to ever go see a doctor, and you can do it yourself. And there are things that we can do here quite a bit. And then there's a bit more problematic conditions that also drive, but we don't know much about them, how we are going to manage them, such as the cognitive impairment. And this happens to be in oldest old groups. These are the things that happen in youngest old groups. These are the things that happen in oldest old groups. And then we did another project, which is still in progress and we are finalizing. And part of my reason for showing some of this data is just to give you some information what kind of research we are doing, but also something Carol mentioned in her introduction, that I'm very interested in collaborations across the globe in order to understand how people age. We have a study recently working with some of the cardiologists where we're looking at, do people in low-income countries, middle-income countries, and high-income countries age differently? And I think this is part of that exercise here as well. So another project where we're looking at impact on multiple chronic conditions and morbidity on mortality rate. And here we basically wanted to see, do certain conditions, when people have them, speeds up the rate of death in comparison to other conditions. And again, it comes down to, it's not that we want people to live forever. The point is that we can do things to increase the healthy lifestyle of the people till they die. We all have to die, but we want to make sure that we stay healthy as long as possible. So this was a study which we did taking the Canadian data, the same data that I described before, and we worked with 4 or 5 European cohort studies and pooled data to see what we can see. And these are some of the studies. And here we focused on, again, big ticket diseases that are the big drivers of the death. So there is cancer, stroke, hypertension, myocardial infarction, that's the heart attacks, diabetes. And we sort of looked at combinations of these diseases again. The interest here was for the researchers in the room that we wanted to look at the rate advancement period. Basically what we wanted to look at specifies the loss of years in terms of mortality risk. So how many years you would lose if you had a particular set of chronic conditions. And again, I don't want you to be looking at each and every bar and each and every number here, but here, this is the diseases on their own. Here's cancer. So you lose 3 years approximately of your life if you have some sort of a cancer. Heart attack, 4 years of your life. Stroke, 4.5. Diabetes, 4.5 as well. And blood pressure, it's only 1.5 years. Start to see when we start to combine these conditions and where the risk of dying goes. Here is a myocardial infarction and diabetes, almost 10 years loss of life if you have this condition. And when we go to 3 conditions, the story here we can do something managing, but when you go to 3 or 4 conditions, actually it doesn't make a difference how many, which set of chronic conditions you are just in trouble. And this is where your chances of living, especially with these diseases, for a long period of time reduces substantially. So there is something we can do here that will prevent us going from here to here. And this is where the clinical research needs to go. And so I'm actually going to skip this slide because I made the point on the last one, but this is the slide which actually takes the message, it's a take-home message from the work we are doing. So if you look at, this is a hypothetical chart. If somebody who had 0 conditions and somebody who had 4 conditions, what this is saying is that, for example, a 65-year-old individual who has 4 conditions has the same mortality risk as a person who is 77-year-old and has no chronic condition. So basically, you have accelerated your aging process because of those 4 chronic conditions substantially. And this is an important evidence for us to start thinking about what do we do about these conditions and which conditions are modifiable and how do we modify them. We have spent an awful lot of money picking diseases individually, but the fact is this is what is happening in the older population. So we got to think of diseases as a cluster of conditions. And we have to think about the consequences of these conditions, not just the risk factors of these conditions. Aging process is slightly different than just thinking about what are the risk factors of these 4 conditions. We have to look at what it does to people when they have these conditions. So what are the implications of this kind of data? Examining clusters of combination of disease requires very large data sets. And that's one of the challenges when we look at multimorbidity or multiple chronic conditions. When you start looking at diseases like stroke, cancer, and heart disease together, those 3 combinations, you don't get a lot of numbers. So you need very big populations to be able to study. For clinicians, implications in knowing which combination of conditions are associated with either functional disability or an enhanced mortality is very important for targeting treatments and how they manage those patients. Implications for policymakers is that they need data for different demographic groups so they can design community-based care or public health interventions that can keep people seeing these people here. So how can we create prevention strategies that prevents people from deteriorating as a function of these multiple conditions and preventing people from going 1 condition to 2 conditions to 3 conditions. So sort of slowing down that trajectory. And so these data have profound impact in how we as individuals, our medical system, or our political system or policymakers work. So as part of our program of research, we think if we are going to understand the multimorbidity and the aging process, and the diseases are part of getting old, so we have to pay attention to them, we really need to start developing more complex research questions that not only look at the things that I was describing you, but we have also started to think about, are there particular biological phenomena happen as a function of your multiple chronic condition that actually could be used to identify people who are in a pre-disability situation, and we can do something about it. So identifying people earlier is going to be the key to slow down some of these deleterious effects on many of these conditions. So we have a program of research which is looking at all sorts of biomarkers, those factors that circulate in our bloods and urine. We are looking at genetic, epigenetic pathways and how these are clustered within the people who have multiple chronic conditions. But this is a big challenge, and this is the setting the stage for why we are doing the Canadian longitudinal study in aging to share with you. So, as a result of these complex questions and the processes that we want to address in the aging population, it's not about diseases. We want to understand why some people age in a healthy way and others don't, and how do diseases and other issues sort of fit into the picture. So the Canadian Longitudinal Study on Aging is an initiative which involves many researchers across the country, many institutions, and it's quite multidisciplinary. It brings people from all sorts of different disciplines. And another unique thing, and it is similar to Midas that is led out of here, is that we are building this as a research platform for all researchers. And because this is a data that is available to any researcher anywhere in the world to access and answer profound questions that will help people immensely. And the opportunity of having this data set is that it can accelerate discovery that can be translated into practice and improving the health of the population. And it is fairly complicated study. You heard a little bit about it from Carol. We are interested in environmental influences. We are interested in how diseases develop and how that is different from the normal aging process. We are interested in looking at the biological aspects of aging and how that in turn impacts the health and social service utilization of the individuals and how eventually how that impacts the processes of aging. And it is a study that we will be done over a long period of time. We're going to follow these people for the next 20 years. And as you heard Carol say, there are 50,000 people in this study between the ages of 45 and 85. We've specifically focused on this age group because we wanted to understand the transitions, how people transition into different health and other areas of aging. And we wanted to see how people who are 70-year-old, 80-year-old transition into more long-term care areas as well. And so we have, within this 50,000, we have two cohorts, 40,000. They only provide data through telephone interviews, but the more intense data is collected from these 30,000 people, where we go to their homes, we bring them to a dedicated data collection site, where we collect a large amount of data. And these people are followed, everybody's followed every 3 years for collection of all this data, but in between each wave of the study, we also contact them and collect additional data. And in Canada, we have a universal healthcare system, and so everybody's health encounter with the physician or with a hospital or the pharmacy, especially for the people over the age of 65, is recorded in a database. So we are also getting their personal health numbers to do that linkage to understand how people use services and how services can be designed better ways. Again, this is one of those slides to check if you're still awake. This is basically tells you what we are doing in the study. It's a long list. We are basic stuff as height and weight, waist-to-hip ratio, blood pressure. We are doing performance testing. We are taking pictures of people's eyes, lung function. We are taking pictures of people's bones, pictures of people's carotid arteries here to see how the arteries change as people age, because one of the things is the arteries start to become harder and develop plaque and calcium deposits, and how that is related to the risk of developing cognitive impairment or stroke. And we are doing fairly detailed cognitive assessment on these people as well. And there are other areas that have not been studied that have a very profound impact on how older people age, and that is the area of oral health, because oral health, the health of our teeth, can determine how people eat. their nutritional intake can change as a function of their hormonal health. So and bacterial growth can have implications for lots of other things. And then we also have a fairly intensive psychosocial data. So when we were designing this study, I knew that we had done a good job in designing this study because we pissed everybody off. The social scientists were angry that we didn't have enough social science data. Clinicians were angry because we didn't have clinical data. Biologists were angry that we didn't have biological data. So my take-home message from that was that we got it right because we have everybody in there. And you can see we collect lots of information here. And of course we collect about lifestyle and behavior, which you heard earlier are very important factors to think about. This slide took me 4 hours to make, so I have to show it to you, because otherwise I have no other audience. So bear with me. This is the blood samples we collect, and we basically take a blood sample or urine sample that we take from everybody, and we put them into 42 little tubes, and we store it in a minus 190 degrees Celsius environment for future researchers to use. So we have a very large biobank that is going to have 6 million of these little tubes stored for researchers to use. So when Hamilton, which is a traditionally steel town like Pittsburgh, whenever I give this talk, I don't think the tourism Hamilton likes it. I say Hamilton has become the urine capital of Canada because we get so much there. And it is true. And we collect lots of different types of biosamples that can be used to do all sorts of exciting research, and we are doing it. And some of those samples we have used to look at different types of biomarkers that are important to understand the aging process. These are some of the traditional, when you go see a doctor does a whole bunch of animal tests on you, and these are the same things we are doing. We are doing some genotyping. But I think one of the most exciting things we are doing within the CLSA right now is something called epigenetics. What it is that, you hear people saying you have this gene, and sometimes the gene is like a switch. You sometimes turn it on, sometimes it is off. But sometimes environmental influences, gene might look fine, but the environmental influences can impact that gene and its function. So you just think about a light switch in a room, and some teenager comes and sticks a little gum after chewing underneath the switch. If somebody came and looked at the switch looks fine, but it can be turned on and off. So that's what epigenetics is. How do you take that environmental debris and it interferes with your gene expression, and it starts a cascade of biochemical mechanisms that can be harmful or sometimes beneficial to you. This is a biological adaptation that happens. And we are interested in looking at that as part of the CLSA because there is something called, there's 21 these markers that have been identified by researchers, tells that there's actually a built-in epigenetic clock. And if you have those 21 markers in you, you're likely to be very resilient to many things and you will age in a very graceful way. But if one of those epigenetic marks are interfered by environmental influences and other factors, your curves will sort of start to go down and you're likely to have some negative experiences. Now, this is done in small studies, animal studies. We really don't have a good idea in real people and large population to work. So here's an opportunity to take something from the lab and take it to the population and see, does it really have that credence in relation to whether this is something to be going after or not. If it turns out to be true, we can actually do lots of things with it because chronological age is not always the best way to define how people are going to age. So if we know there's a biological age built in, and that can predict where people are going to be if they don't take care of themselves, we can help them modify their lifestyles and behaviors that can put them on a different trajectory. So that's one of the exciting areas that we are interested in. Baseline data has been finished, and we just made this first data set available to researchers, and if there are researchers in this room and you're interested in accessing these data, please feel free to contact me and we can make sure you have these data. And you can go to our data preview portal and see what type of data are available. This is mostly for researchers in the room. And we also started on the follow-up. As I mentioned, that we're going to follow these people for the next 20 years, and we go back to them every 3 years. And the next follow-up will finish 2018. And we've added a few new things into the mix as collecting. We wanted to see what happens in early childhood, especially child maltreatment, and how that is related to later life. Elder abuse, I don't know how big an issue it is in the US, but it has become an important policy issue in Canada. So we have added issues of elder abuse. It's not just the physical abuse, it's also the psychological and economic abuse that goes on. Some of the epilepsy. Epilepsy, interestingly, is a disease of the younger people and the old people. But there's very little data on older people, and that's one of the new modules we have added. And we also wanted to do something about what happens to people just before they die. What is the end-of-life experience there and their families? So we are developing a decedent information that once people have died, we go to their family members and ask what was the experience, the dying experience of a person. And some of the other areas. And we have a new area which is around sexual orientation and gender identity, and we want to look at that as well. So you need data like that to be able to answer questions like that. But this is where my plea goes to researchers in the room here, that we got to collaborate more to be able to answer some of these complex questions. 50,000 people that we are collecting as part of the CLSA is really not large enough to answer this question. We actually need 100,000 to 200,000 people to be able to do it. So we need a global collaboration to be able to really understand some of these phenomena. So here I come back to my Mr. X. We started with this. Here is Mr. X, shows up for a visit and has blood pressure we talked about. And I showed you some of the data earlier on in relation to multimorbidity. And this person comes and says, you know what? I have a really bad arthritis pain, I want some medication, but the person has some other conditions. The question is, what should be, in an ideal world, what should be the conversation between the patient and the physician? What information Mr. X and his doctor should use to manage these multiple chronic conditions? Because it's not about chronic condition, it also results in polypharmacy, like multiple chronic conditions that can have multiple negative consequences for people. Because drugs are basically little poisons that help you, and too many of you take, that causes more problems. What are the implications of giving him another medication to control pain? Because in this case, this person has high blood pressure, and we know from data that some of the arthritis medications actually make high blood pressure worse. So should this person be given the arthritis medication? So understanding what implications these diseases have together is important to managing and caring for that particular person. And where should they go to get that information? You need trusted source. I'm a fairly well-educated, knowledgeable person in this area. If I go on the internet to find information, I have no idea what is good and what is bad. And then we have some remarkable TV personalities who send us on a very bad track, like Dr. Oz. And so what we need is a good quality evidence that doctors and people can use. And the idea is to reduce the noise. There's so much noise out there. What is good, what is bad, that's what we need to do. When I was doing this longitudinal study in aging, in the middle I started to get phone calls from some of our participants. And they would say, how come you're not collecting data on coconut oil? This is really curious. All of a sudden, in 1 week, we had like 10, 15 calls. And so I phoned up my geriatrician friend and I said, Chris, what's going on here? He goes, don't talk to me about coconut oil. I said, how come? He goes, every other patient I see wants to know how come whether they should take a coconut oil to improve their memory. Guess where that came from? Dr. Oz. So, and he's a very credible voice. He's a cardiac surgeon, people listen to him, but every other day he has a miracle cure for obesity. How many miracle cures you can have? It's not a miracle anymore if there are 50 of them, right? So we need good evidence to be able to communicate to people what works and what doesn't work, and what is a hogwash in many ways. And we actually did a symposium like this in Hamilton, where we actually did a session where we said, do celebrities do more harm than good? And we actually invited the medical advisor of Dr. Oz to come be part of the panels. And it was very interesting how they think about science and evidence, what works and what doesn't work. And it is on our website if you want to ever hear that particular dialogue between researchers, doctors, and the celebrities. And so you need a user-friendly and accessible information, and you need it in many ways because many of the older people don't have access to the internet. So you have to be able to disseminate that information in a way. So this is something Carol mentioned that we, and this all started because when I started to hear about coconut oil, and I went and talked to a couple of my colleagues who work in this area. I said, guys, this is just ridiculous. We've got to do something. And McMaster is one of the few places, actually McMaster is the home of the evidence-based medicine. That's where this revolution of evidence-based medicine started. Dr. David Sackett, who's an American, who just recently died, who became the first chair of my department, and he basically created this whole revolution in relation to how physicians should use evidence to treat patients. And you won't believe, till the early 90s, less than 20% of the physicians actually use scientific evidence. The rest was their own experience and all of that to treat and manage patients. And surgery is still one of those areas where evidence sometimes is lacking and not being used. So we started talking about creating a platform for Canadians, but is available to people all over the world, is that how do we sort of generate and collate and present good information for people to use. And this is the McMaster, it's called the Large Optimal Aging Initiative. We were very fortunate. There's a person, Suzanne Labarge, very bright woman, who funds my chair as well as has funded this initiative. And she is very dedicated to the area of aging because of her experience with her own parents. And so she did a philanthropic donation to help us develop this platform. And basically what we are trying to do is to scientific evidence about how to stay healthy, active, engaged as we grow older. So basically what the science says. We also, much of the data, much of the information on this website is for people like yourselves. So you can go and read it and see what is there. And we also provide for clinicians and policymakers. And we have three major data sources at McMaster. One is in the clinical area, Dr. Brian Haynes, who assembles every possible publication that is out there that has a clinical relevance related to any disease, any age, any population. And he has a network of scientists and physicians across the world who look at that particular paper that has come out, look at the quality of it and clinical relevance of it. So he puts that into the data. So we use that database to define what is good, what is bad, and how we should share it with people. And then we similarly have in public health, as well as in health system and policy side of things. So these is Brian Haynes, Maureen Dobbins, John Davis, and Anthony Levinson. And Brian Haynes is well known in the clinical area, and so I'm not a smart person in the room, I just picked their brains to create something like this, and they're the ones who are actually driving this whole McMaster Aging Portal. So what is the Aging Portal? I have 15 minutes to my time, so I'm sure I will finish on time. We have evidence summary, so because scientific papers, I know during the lunchtime, I was listening to a gentleman sitting behind me, and he was reading the title of the award winners, and there was something, a novel mechanistic approach to understanding dysglycemic, blah, 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 right? And the question is, that's a lot of technical jargon. Average person doesn't understand. And so we have to take the scientific information and put it in an easy way so people can understand it. So taking these scientific papers, we actually create evidence summaries. And then, as I mentioned earlier on, that we also have lots of internet information. And some is good, some is bad. And so we actually go and rate different websites based on where they get that information. Is it based on science? Is it a good quality science? And then we give them the rating. So it's like a Rotten Tomato rating for websites. And it helps you when you go and see, yeah, I can go to this website and trust it, what information they're giving. Because there's a lot of crap out there. And then we also have blog posts where we identify experts, we give them evidence and we say, okay, write it in a bit of a narrative repetitive, simpler way so average person can update that information and use it when they have a dialogue with their physician. And then you have email alerts. You can sign up, register, and you will regularly get an email. We have a new blog, or we have a new evidence summary in this area, that area. If you're interested, you will go and access it and use it for your own purposes. And the same thing is done with the clinicians as well as with the policymakers. Basically, this is what evidence summary got key messages from scientific research written in plain language, translated from our jargon, and ready to be acted upon. Here is an example of the summary. Blood pressure lowering drugs reduce cardiovascular events, most in people with highest initial risk. And then it gives you in a very simple way what's that paper about. And then I already talked about web resources, we rate, and so on and so forth. And this is what it will look like. Alzheimer's disease, can ginkgo products help? So we went to this website called Informed Healthline, and we want to see how did they come up with that information. So we looked behind their information they had. It was based on scientific work, which was of a decent quality, and they got a rating of 5 stars. That doesn't mean ginkgo works. Question is, the information they had was from a good source, and they have translated it well. And they get, so in that case, we don't need to replicate that kind of in our portal. We just use that information to disseminate. Blog posts, what are they? They are commentaries on what the research means, translated again, presented in article form. These are some of the blog posts we have. Preventing the flu. Do vaccinations really work? But what does drying clogs have to do with driving cars? Because it's an important, I don't know if it is here in Wisconsin, but in Ontario, the province I live in, when you turn 80, you have to go for a mandatory driver's test. And one of the things they do is to look at the drying clogs. Do people have some sort of a cognitive impairment that they shouldn't be driving? So people always wonder, what do I have to do? These clog drawings, what does it really mean? So we sort of show that here, what does that mean, and what is the evidence and the science behind it. And here is the benefits of exercise for older adults with dementia. So these are the hot topics that people want to go after. And this is what it will look like. It will have some information about what research tells, and then we give the bottom line to take home. Say, numerous studies have confirmed the benefits of regular physical activity for older adults, including prevention of slips and falls. Because we wanted to also give positive message. We don't always want to give negative message saying there is no data, because that happens a lot, and people get tired of it. So we say, yeah, there is benefit from exercise in relation to slips and falls and other things, but exercise and dementia, there's a limited information. We need, exercise is good, you don't want to stop, but it might not help you memory yet. The data are coming. And trajectory is that there is some evidence. There is a recent, very large review that has come out, as probably not. But this is an evolving area, so we wanted to make sure that people don't stop exercising because it doesn't work for their brain, but it is important for other areas as well. And as I said, it's for professionals as well. So email alerts, lists of new contact links recently added to the portal. Click on, there's a link that comes in your email. I gather most of you have a cell phone, and you can get it on your cell phone, and keeps you up to date on what is out there and what you should be doing with that information. So now I come back to our Mr. X. So we looked at the data. We talked about where the research needs to go in order to help Mr. X, but what we already know, what can we do for Mr. X? And here, Mr. X and Doctor went to the Master Optimal Aging portal, found out what was available in relation to how the management of arthritis and hypertension together can be done, what are the negative, harmful things the medications do. And based on that information of how bad the pain was, they decided that he will not be prescribed arthritis at this point in time. They're actually going to try to do some other things, which is lifestyle changes. That not only will help him manage his hypertension better, but also allow him to reduce the arthritis pain is not going to be disappearing, but how we can make it manageable. So he doesn't have to go on another medication, which could actually accelerate his decline, his functional decline, and end up in a long-term facility. So hopefully I convinced you how we use science and how we simulate science and how we take it to the hands of the people and clinicians to help them. If you want to go to the Master Optimal Aging portal, this is our website. Please go and register. I'm hoping that by the time I get home, there will be 650 new registrants, because your feedback to this whole process is critical. What you tell us will be important for us to know so we can improve this site. And I think it is a unique resource. I don't think there's another resource like this anywhere, the level of information for that. So please see if you're interested in looking up what we have. And if you have any questions, please contact me on my email. And thank you very much for listening to me.